logo, how much it costs to put inside logo there? Yes. How much you put inside your logo every day? How much? Yes. 100,000. So before you say we are missing, you need to understand the priorities. That's the only job you make this job. Take the money and the paper.
That's right. That's what the big buy shares from the adolescent company. Whenever we see the keep it with this is our fault.
This is
Somebody must do it. Very, very important.
Good morning, good morning, good morning. Bonjour, bonjour, bonjour. We are getting ready to start. Please, can we take all our seats? Can we take our seats, please? I can see that the room is half full, not half empty. I'm hoping that many more colleagues are working for this plenary. But I think we are ready to start so that we will not eat into the time of the other session. It's my pleasure to invite the 3 chairs and the 3 speakers to the podium. Please. Okay, welcome to this morning's parent session. We are lucky to have a very distinguished panel. We already have our chairs, 3 of them, and our 3 distinguished speakers on their seats. So I guess we are ready to start. During this plenary, we'll have all the speakers. After the speakers, we will have a short award ceremony. And if there are any announcements, so it is now my pleasure to introduce the first chair. And he is in the person of Dr. Al-Hassan. Dr. Al-Hassan is an advocate on public health policy, an expert in resource mobilization, partnerships and coordination, and an academic. He has extensive experience working with the corporate sector, governments, and international development partners, including USAID and PEPFAR. He has worked with Nigeria's National Agency for the Control of AIDS, where he served as the Pioneer Director for Resource Mobilization. He was also Director for Partnerships, Coordination, and Support. He was a special assistant to the Honorable Minister of Health. He was also the project manager for Nigeria's second World Bank Intelligence Program. Dr. Hassan holds a Master of Science degree in organizational psychology and an MBA and PhD in psychometrics. He's a senior executive fellow of the Harvard University Kennedy School and a certified public-private partnership specialist. He's also a fellow of the Institute of Cooperative Administration of Nigeria. Dr. Hassan currently teaches psychology at the National State University in Nigeria. He is also the Nigerian coordinator of the Global Health Advocacy Incubator Epidemics Prevention Program. Now, my pleasure to invite Dr. Hassan.
Good morning. It is my pleasure to introduce the first speaker, Dr. Tendani Gaolathe. Dr. Gaolathe is Assistant Program Director, Department of Internal Medicine, University of Botswana. She's also the Project Director of the Botswana Harvard AIDS Initiative. She's a lecturer in the Department of Internal Medicine and chairs and serves on the Ministry of Health and Wellness National HIV/AIDS Treatment Guidelines Committee and advisory to numerous technical working groups. She also served as a research associate of the Botswana Harvard AIDS Institute Partnership and is currently assisting Rutgers Global Health Institute in laying the groundwork for collaboration between Rutgers and the University of Botswana. Through the Botswana Harvard Institute partnerships, PEPFAR training and capacity building program, Dr. Gaolathe has served as Principal Investigator on 2 cooperative agreements and led the Botswana Harvard Master Trainer treatment and education effort, which has been instrumental in the successful rollout of antiretroviral treatment clinics, task shifting, laboratory decentralization, and national monitoring and evaluation efforts in Botswana. Previously, she worked at Princess Marina Hospital in Gaborone,
Live streaming.
first as a specialist in internal medicine, and then as an interim director of the facilities DRA Clinic. A native of Botswana, Dr. Gaolathe earned her medical degree from St. George's University in Grenada and completed her medical residency at St. Michael's Medical Center in Newark, New Jersey. Ladies and gentlemen, please put your hands together for Dr. Tendani Gaolathe.
It is my pleasure to be gathered talk on optimizing second and third line regimens that from the system now. Have the slides on. So that is the topic for today. And next slide, please. So, in the context of the 1992 All Targets for 2020, my focus is on HIV drug resistance. I will try to keep it simple, but just to refresh our memory on what by these targets. By 2020, 90% of all people living with HIV will know their HIV status. By 2020, all people diagnosed with infection will receive sustained antiretroviral therapy. And by 2020, all people receiving antiretroviral therapy will have viral suppression. So this top week will put emphasis on the third 90, where we talk about viral suppression and then the implications of HIV virus. So with these ambitious targets to help end the AIDS epidemic, there is a movement, and this is HIV drug resistance that we need to tackle. And for sub-Saharan Africa and low to middle income countries. This is a result of our weak health care systems and poor access to diagnostic and monitoring tools. I say so because of what we know in our clinical space on how our patients do on antiretroviral therapy. If all things equal, they got what they needed. One, we know that with the evolution of the ARP programs, we have been through different regimens, which essentially means that for most of our national programs, we have different cohorts. Most programs started in the early 2000s, so you will appreciate that the first cohort really was on the ACT 14 departments in the therapy line. With moving on with the WHO guidelines to the tenofovir-based regimens, and now with the current 2019 WHO interim guidelines to the tenofovir-based regimen. For most of the continent, access to diagnostic and monitoring tools was not met with much lobbying as we did for the drugs. Hence, to some degree, we are paying for that lack of the essential implementation of what should be the diagnostic and the monitoring tools for monitoring our program. Well, I guess we all know that if left unchecked, the potential for explosion is great, especially in the setting of limited treatment options for our program. Next slide, please. What does it mean? With drug resistance, it will make it difficult to treat and manage infections. Not because we don't know what the problem is, but simply because we wouldn't have those choices in terms of drugs. That would necessarily need to translate to reducing morbidity and mortality, we will talk about later, and directly affecting the sustainability of our treatment program. Next. So before WHO switch to the DTG-based regimen, there have been several modeling studies by different groups. Here I'll just talk about the two, and one by et al. And also by the South African group. So these modeling studies were really based on the past situation, the past regimen, which was tenofovir-based FTC, BTC, and departments, or what is commonly called the TLD regimen in our setting. So for those countries where there would be greater than 10% HIV drug resistance, assuming there have been no change in the regimen, we would be looking at 190,000 additional deaths, translating to 10% of all incident deaths from drug resistance. Over 400,000 new infections with drug resistance, accounting for 9% of all new infections, and an extra 8% of total cost for our ART program globally, translating to about 6.5 billion. Trying to model on the more optimistic side, if we were not to change the regimen, we can also see that the numbers are still phenomenal, even at less than 10% of HIV drug resistance. Over 700,000 deaths, 800,000 infections, and 5 million in cost that relates to drug resistance. So maybe before we continue, next slide please, we'll talk about the definitions of drug resistance for the benefit of those who may not be clinical setting. So as relates to this talk, when we talk about higher HIV drug resistance, this speaks to persons on ART who develop drug resistance while on therapy. And it could be a result of many factors, which we will discuss later. That may include some therapeutic drug levels, adherence to drug interactions, patient-related and non-patient-related, or even just drug combinations that we give. Then we are going to talk about transmitted HIV drug resistance, here. This is really occurs in the unaffected treatment-naive person who may get it from someone with a drug-resistant mutation. And pre-treatment drug resistance may be detected after initiating first line or initiation. And a lot of this may be from previous ART regimen in one form or another. And this also is quite common in our setting, especially for women in the old guidelines from the PMTCT perspective, where a lot of women may have been started on prophylaxis for the infant's benefit and later taken off before we proceed on. So this slide just depicts on how resistance may develop. I think in the clinical setting, it has always been a bone of contention in that for caregivers, when you don't see the numbers we want or the viral suppression we expect, a lot of the time the blame and the pressure has been put on the patient. And sometimes for the patient, they are doing all that they should in all the possible ways, but still not suppressing. From the adherence aspect, this may be from social and personal issues, where clients may not take medication as scheduled. For some, adherence, as we know in the past, some of the drugs were very toxic. And it made it a challenge for one to keep on the drugs all the time. Insufficient drug levels, a lot of the times, attributed to the healthcare system and the healthcare provider issues. So, poor potency drugs, wrong dosing, there are issues of both genetics, absorptions, two absorptions, especially with comorbidities, rapid clearance or poor activation because of drug-drug interactions. And of course, even with the natural evolution, you may have viral mutation in the presence of drug, hence resultant mutations. Next slide, please. So this is just a snippet from a study based in Botswana by Diouf et al. And here also they have modeled pre-DTG era. And that model mainly looked at two aspects. Based on the 500 C4 count threshold from the previous guidelines and the fast track for treat all. Next slide, please. This really depicts what they were looking at. Unfortunately, there's no pointer. So, like I mentioned, the 500 and the fast track reality. Next slide, please. And there are simulations based on that on the last guideline regimen. They had predicted that by 2030, the median total resistance could be as high as 31.4%. If the guidelines have not changed and they stay on the 64-based ART using that 500 threshold. But they also postulated that even with treat all, the regimen had not changed the DTT-based regimen, we would still have been seeing a median percentages of drug resistance at about 14.5% on the fast track implementation. And of that, maybe 48% of the resistance would have been from acquired drug resistance. And here they were just looking at the breakdown in transmitted resistance and incident infections. So really, they had concluded that our programs would need to step up effective surveillance mechanisms. And programs would really need to consider utilization of second line alternative regimens as a first line defense. Remember at that time our second line was diabetes. But really, they were just saying that with the TAE recommendation, indeed it was a time bomb for substantial drug resistance. So with that, the WHO has been hard at work, and as outlined in the Global Health Plan from 2017 to 2021, launched in response to these issues around HIV drug resistance. I must say, since the advent of most of our programs, WHO has always been an active arm of HIV drug resistance, I think led by Sylvia and team, but a lot of our countries had not heeded to the warnings or even implemented the recommendations. I know the greatest excuse has always been around funding, that for some activities to happen, there's always that expectation that they should be funded from someone. And between 2004 and 2018, 49 countries had actually implemented surveys using the standard methodology at different times. I'm quite embarrassed to say that I know Botswana we have implemented 1 or 2 surveys, but the current we are behind. So here I'll just take you through the WHO 2019 report that we shared, shedding light on the overall HIV drug resistance. Next slide, please. So this is just a map of the drug survey resistance surveys that have been done since 2004 and 18. And with the different shades, you see that Middle East Africa is doing quite well in terms of recency, in terms of the drug studies. And for those who guessed times, unfortunately, there's no pointer. We are planning, so we're hoping to have this in the next year or so. Next slide, please. So what did the surveys yield? Here I'm just limiting it to the sub-Saharan countries as much as I mentioned the global picture. So 12 of the 18 countries reporting data between 2014 and 18. It did show high levels of treatment drug resistance, prevalence and nevirapine among first-line patients for ART. I think this is not surprising because for the longest time I've been using NRSTS and also for what will allow the genetic barrier to resistance. It also did show that overall it was twice as high in women versus men, which is not surprising. The majority of patients on ART program are women, and also from a PMT perspective, a lot of women who have been exposed to these drugs. Next slide, please. This just shows some representation focusing on the sub-Saharan African countries. In there, we see that those are the predicted drug resistance patterns, less than 10%. So you will see that Cameroon is quite well there. Swaziland for the men. And in red, the 10 to 30% threshold of drug resistance. And most of countries in Southern Africa do fall into that category. And greater than 30% in Namibia for some reason. And of those who had prior drug exposure, it's going to spark. Next slide, please. With the alarmingly high pre-treatment drug resistance, for our setting, implementation of viral load monitoring has put us back. A lot of our countries for the longest time was using clinical and immunologically based algorithms to predict failure. Not that there was never that recommendation that viral load monitoring would be the best way to go, but for many reasons known to our programs, it had been fully implemented in the continent. Botswana was probably one of the very first countries who adopted viral load monitoring from the first day when the ART program took on. Hence, some of the data from Botswana will give us insights into the magnitude of the programs. And I think it was only proper that at this time WHO would recommend the Kanem as a first-line regimen, with all the challenges or all the emerging evidence that we have also regarding this dolutegravir. Next slide, please. So, what would this mean in the form of differentiated care? Most of our healthcare systems, actually more than 90% of care in provision is being facility-based. Hence, the call for new approaches for patient-centered strategies to promote quality of service delivery, while also recognizing the different characteristics of beneficiaries. I know we implement a public health approach, but to some degree, the differentiated care approach then some service to individualized care. Hence, the need to move from a one-size-fits-all approach. So I think the greatest call now is for our programs to look at the design and delivery of our services for the different populations to enhance quality, efficiency, and patient satisfaction. I think I have a snippet, ICAP, the Colombian group. We learned a lot from them in terms of that aspect. Moving on to the next slide, just an example on how differentiated in the context of HIV being looked at. Next slide, please. I think also speaking to differentiated care, we should also not forget the integrated aspect of care, because here we just focus on HIV, but it is still the same patient who seeks all other services for all the other comorbidities, challenges, intervention packages that they need. And here's just an example of how they have looked at differentiated care for people with HIV, in the sense of whether they were new initiates or had been on ART for some time, whether they had early disease, advanced disease, was stable or unstable. And maybe for those with advanced disease or unstable, needing to meet their needs. Next slide, please. So really just an example in how an actual concept we wanted to find your package for the health patients or new initiatives based on CD4 counts. Why? It has implications for prophylaxis issues and so forth. WHO staging and the support systems around the first year of therapy, or for those who may have been on treatment for more than a year or unstable, and all the factors that may affect clients and how we want to deal with their challenges. Adverse drug reactions, being on treatment for long long-term effects of some of these drugs, issues of substance abuse, or any other social issues, alcohol. We still have C4s, less than 200, even for those on therapy and other comorbid conditions, hypertension and so forth. Next slide, please. Now, looking at the bottlenecks for HIV drug resistance, I sort of keep on emphasizing on viral load because it has always been the bottleneck. We know it is the bottleneck, but I'm not sure that we have worked hard at program level to see how we can overcome this. Cost is still an issue. The lobbying has not been that great in terms of reduction of cost. We have had new innovative measures, point of care, viral load, and so forth, but and also treatment access. But I'm not sure that it translates to reduction of costs. It is estimated that even with this call for treat or in 2019, less than 50% of all programs actually implement viral load monitoring. So this is a call for programs seriously look at this issue of implementation. For a lot of countries, we're still behind in the sense that even in programs where they need high baseline drug resistance, we still do not have the capacity for baseline drug resistance testing. It has really limited to surveillance, but not at individualized patient care, save for very select research projects or programs. So we would also need to look at issues around drug resistance testing at the individualized clinical level. And of course, putting into place the appropriate algorithms, because it is not necessarily a cheap exercise. So we have said a lot of drug resistance was not necessarily patient-related, but system-related because of the use of critical and failure criteria. For those in the health sector, you know that the longer you are on a failing drug, the greater the mutations. And by the time it's manifesting immunologically or clinically, we have really progressed. And the greatest excuse has always been the cost of viral load monitoring. And how it has impacted our programs, it made it difficult to monitor our viral loads. And was very difficult to predict the durability of the regimen patients' levels. So really, from the Botswana program, which had instituted viral load testing from the beginning, we have presented at numerous conferences in the past, as early as 2004, in terms of what we were seeing for failing patients. At country level, was still below 10%, even though the pediatric population, I don't have the statistics, but it is higher than the adult population. We had seen on average, even with viral load monitoring, the time from initiation to first dose treated failure changed to second line regimen. In the early years, it was as high as 466 days. But we did see that with the second guideline and change of regimen, it was actually coming down. It was just like over 360 days. So that is to say, even using that as a proxy for programs that promote viral load, you will also appreciate that even with this monitoring, patients still fail for all the many reasons that we know. So just looking at the tenets for addressing drug resistance, I think also as homework for us, it is around the 3 areas of prevention for drug resistance, monitoring, and even at that, how do we respond to the data from our surveys. From a prevention aspect, it still is, I can't really emphasize it more, viral load monitoring. And also, where feasible, we need to also look at speeding up resistance testing, whether baseline or just at programmatic level for clinical utilization when we look at our drug algorithms. We need to monitor. Next slide. A lot of our programs are disjointed in terms of monitoring, in terms of data collection, because it's not centralized, and hence it can be a challenge for global intervention of this program. We do appreciate and we hope as we all move to drug resistance surveillance, it will be done on a regular basis, not only generalized surveillance, but also looking at other pockets of high-risk groups where we may also want to implement surveillance, be pregnant women, being hard to reach, or any of the spark populations that we think may be high risk. Even to this, for routine program monitoring at facility level, there has always been the recommendation for the early warning indicators that maybe we just sing praise, but we do not implement or use the data to inform at least the clinical level our everyday activities. So I think with this, we have a new lifeline in terms of our programs. And this new lifeline being in terms of the newer regimen and drugs that are coming up in response to drug resistance. The new line really that most of our treatment cohorts in the national programs have not used before. And hence, I think the adaptation of the WHO guidelines. I won't say much in terms of, even this, we know these guidelines are never static. You know, there's already talk of a two-drug regimen, switch regimen from studies that are ongoing. And even with this, it has been a challenge to discuss even the third line regimen after failing DTD as first or second line and the use of PIS, but that is something that should be on our radar. I think also as a country, we've been one of the first to switch to DTD. In many ways, we are also buying time in terms of our 3.5-year experience now in terms of what we're seeing for DTD-based regimen and drug resistance. So the next slide just depicts how a lot of the countries actually did this in terms of response in the subcontinent that you see has already been integrated in their guidelines. Uganda for resistance, Republic and Democracy reported the number as high as 15.4%, Zimbabwe 10.9%, South Africa 23.6%, Eswatini 10.5%, and Namibia 3.8%. And you see all of these are programs. Next slide, please. I think we can skip this and skip the next slide. I think on the treatment algorithms, for those who work in the clinical space, it's just how you would interpret and also take into account the patient's practice. Even with the advent of DTG, there will be some element of recycling of at least the NRPIs and how that is sequenced. And how we may use situations where we don't even have a choice. This slide just summarizes the WHO first, second, and third line regimens that's recommended at this point in time. And the next slide just speaks to the common mutations or signature mutations. Next slide, please. signature mutations from the previous regimen. From the NRTIs, most common, and how they may have impacted this. So just looking at the genetic barriers to resistance in the next slide, it does show DTG, the higher, and the possibility of a second line of the line base regimen in terms of the high genetic barriers. And the previous guideline drugs, all of them having low genetic barriers. Next slide, please. So really, at this time, the integrase strand inhibitors are the best option. I did allude to the fact that it may just be a matter of time before we have to get back to the drawing board. And just the question of the use with an optimized regimen. Next slide, please. So this is just an excerpt for our national program Botswana on the use of Gaolathe. We implemented treat-all DTG-based program in June of 2016, and to date there are now over 100,000 patients on regimen. So, but we are happy to note that even with that, to date with viral-based monitoring, we have not identified resistance in treatment-naive patients. We have had minimal side effects, most of them restless upset depression, even though now we are looking into the new reported issues. And even with this program, 8% had viral loads within 12 months with greater than 95% suppression. The program allows it just shows to a gap in implementation because it should be 100%. So let me just skip to the summary slide, next slide, and next slide. HIV drug resistance can be minimized through concerted efforts to improve delivery ART program delivery performance. And the WHO recommendation as a preferred line simply because of its effectiveness and high barrier to resistance, and really access to diagnostics and monitoring can mitigate the effects of drug resistance. Thank you.
Thank you very much. I have the pleasure to quickly introduce the second chair. He is Mabinge Ngom, who is an experienced global leader with a strong track record of turning ambitious certification into change for women and young people. He has led transformative change, such as the demographic dividend agenda, the heads of state, and UN Secretary General, and leveraged investment for Africa's biggest asset, its young people, especially young girls. Mr. Ngom pioneered new ways working around alignment, optimization, quality, and effectiveness to support the UN reform agenda. He has built innovative partnerships for change, such as the Sahel Women's Empowerment and Demographic Dividend Initiative with government, the World Bank, and the UN. Since 2015, he's been overseeing UNFPA's humanitarian and development programs in West and Central Africa. Between 1998 to 2015, he held leadership positions with the government of Senegal, the International Planned Parenthood Federation, and the Global Fund, at the UNFPA headquarters in New York. Mr. Ngom is the national of Senegal. He has master's degrees in economics and development planning and in public policy from the American University in Washington, D.C., USA. Please welcome Mr. Ngom.
Thank you very much. Good morning. It's my pleasure to introduce Mrs. Cindy Kerry, Executive Director of Bonella. Mrs. Cindy Jeremy is the Executive Director of the Botswana Network on Ethics, Law, and HIV/AIDS. Mrs. Jeremy is a renowned activist who has impacted the response to HIV/AIDS in Botswana, regionally and internationally. While at Bonella, Mrs. Jeremy coordinated the first ever treatment literacy program in Botswana, which empowered over 50,000 people living with HIV/AIDS with the science of HIV, the benefits of treatment, and associated side effects. This became the biggest HIV movement in Botswana, which advocated for access to HIV services, monitoring of drug stockouts, and holding duty barriers accountable for service delivery, while advocating for inclusive and enabling policy and legal environment. The highlight of her career was when the organization she leads, Bonella, successfully petitioned the government of Botswana to the courts to ensure provision of HIV treatment to foreign prisoners held in Botswana prisons. Mrs. Kennedy joins other activists to call for an end to dwelling donor support for the HIV response, complacency, lack of accountability, lack of right-based and community-centered approaches, criminalization of HIV, and most at-risk and vulnerable groups, such as sex workers and men having sex with men, among many challenges facing the end of HIV today. Please join me to welcome Mrs. Cindy Kennedy.
Thank you, Honorable Chair. Ladies and gentlemen, and those non-conforming, a very good morning to you. I am indeed honored to be here delivering this talk. And my topic is on political leadership to advance SDG 3 and promote inclusivity of vulnerable populations. I just decided to remind us, if we may have the next slide, please. I have just decided to remind us what SDG 3 aspires to achieve. We are saying that we want to ensure healthy lives and promote well-being for all. Ensure healthy lives and promote well-being for all. I would like for us to spend a bit of time reflecting on that aspiration, particularly looking at the key words. For me, if we are saying well-being, promoting healthy lives, ensuring well-being, this suggests to me that we are prepared to move beyond health, to actually look at other determinants of health. It also suggests to me that when we say all, as we all know the definition of all, meaning with no exceptions. So the big question, I think, that is before all of us is how are we going to address issues around inequalities, socio-economic differences, gender inequality, poverty. These are some of the issues that as we look at SDG 3 and its aspirations, we should ask ourselves, are we prepared as a system, as a sector, And are we ready to achieve the aspirations of SDG 3? Health programs, therefore, must engage with the socio-political context in an endeavor to leave no one behind. But I guess what my topic is requiring us to do is to recognize the role of leadership in ensuring that this aspiration is achieved. And the question is, why do we need political leadership for health? We know that we live in countries across Africa where there is competition for resources. So if we do not make health a priority for the politicians, then they will prioritize other things other than health. And therefore our aspirations will not be met. We already know that we have other aspirations that we have put forth before, but have not been able to achieve. We also need political leadership for health, because we know that politics has been the main driver of action, as well as inaction. So we cannot say we want to only focus on health or ensuring well-being without involving or ensuring that politicians or politics is part of our agenda. We also know that positive political action, both at grassroots and governmental levels, impacts on the health outcomes. We also know that politics sometimes, or more often than not, in other parts of the continent, has blocked very important policy developments and evidence-informed action just because there was no political will. And we also know that politics has been sensitive to certain issues that we know as programmers have to be done for us to achieve our aspirations. We also need, beyond health, we need political leadership for HIV. HIV is one of those diseases, unlike other diseases, that are associated with stigma and discrimination. I've already alluded to issues around social and economic inequalities and other injustices that come as a result of HIV. And we also know that AIDS is one of those diseases that has enabled us in our respective countries to see the weaknesses in our political systems. We know that issues of corruption have come to the fore because of HIV. We know that procurement processes have been a challenge for us because of HIV. And we know that health systems are weak as a result of the burden that HIV had faced or has faced on the health system. So we cannot achieve our aspiration of a healthy citizenry if we do not engage politicians, if we do not engage political leadership. Next slide, please. Next slide. But then I ask myself, is political leadership enough? Is it the only ingredient that could possibly take us to where we want to go? And my answer is that political leadership is important, it is critical, but it is not the only vehicle. We need to look at the broader spectrum of leadership. And as far as I'm concerned, there is some very special leadership that emerges at the level of the citizenry. And that is why it is important that when we design programs or when we deliver interventions, we should not take our people for granted. There is a certain leadership that they possess that we should recognize and be able to use for the benefit of our programs. We also have, coming from an African context, the community or traditional leadership. That is an important structure. Back home in Botswana, you can't enter a village before you first start with the chief. You can't address the villagers before you address the chief. So they yield a power that if we harness, it will be able to help us to achieve our aspirations. The other layer of leadership that is important, critically so because I form part of that sector, is civil society. Civil society is key in terms of mobilizing people, in terms of ensuring that they identify, especially areas where our programs are not reaching. And of course, the religious leadership. This whole talk is about political, both at national and sub-national. So in my view, if we are to look at leadership as a collaborative effort, it will help us in terms of achieving our goals. Allow me, ladies and gentlemen, and non-conforming, to use Botswana as an example. And this is an example about leadership. And I call it the coin syndrome, because a coin has both sides. Botswana is one of those countries that are regarded as a leader in the HIV response. We were one of the first countries to roll out free antiretroviral treatment to our citizens. We were also one of the countries to reach a significantly low transmission rate when we are looking at PMTCT. There is more that we can do there, but we have done significantly well. All these achievements, all these milestones, we were able to achieve them because of a strong leadership. We had a president who, against all odds, against all criticism, vowed that ARVs will be provided to Botswana, regardless of what the cost is. He went around the globe gathering support for our program, and we had a successful program. But I must hasten to say that we are just like all other countries. Resources are limited. So government makes decisions about who to prioritize for ARV treatment. Next slide, please. And this brings me to the other side of the coin. I work for a non-governmental organization called Bonella, as it has been said. And part of our role is ensuring access to justice for those whose rights have been violated. And I remember vividly in 2008, a gentleman, Mr. Mube, which is not his real name, walked into our offices He was heavily guarded. He was coming from prison. He was HIV positive and had never been initiated on HEART. He looked really sick. And that was my first time to come into contact with someone who is near death. I'm not a doctor, but I think he was. We sprang into action as Bonella. Bonella lawyers began to help him. But in less than 2 weeks, our client had passed away, and we were unable to help him. So this helped us to start a campaign, an advocacy campaign, to raise awareness about HIV in prisons and raise awareness about prisoners' rights. We emphasized the public health benefits of having prisoners on treatment, including non-nationals. We engaged, we negotiated, we pleaded, but all our efforts fell onto deaf ears. We then embarked on a legal struggle in order to ensure that prisoners living in prisons in Botswana have access to treatment. This battle started in 2012, and it took us a good 4 years. No, sorry, 2 years. We went through all the court processes from the High Court to the Court of Appeal. And that is where we were able to put the case to rest, as non-national prisoners in Botswana were granted access to antiretroviral treatment. I am juxtaposing the two sides of the coin to help us see the kind of leadership we are dealing with in Africa. I know it's not only in Botswana, this kind of leadership is there elsewhere. So if we do have leaders that on the one hand acknowledge their responsibility, but on the one hand are able to let the ball drop, then we have a problem. And our SDG 3 goal, we may have challenges in reaching the goal. So what lessons did we learn going through this process? We learned that health, including HIV, is political. We also learned that civil society has capacity to hold political leadership to account. And we also learned that any intervention must engage the political process. Allow me also to reflect on the role of civil society with regards to speaking truth to power. I know as civil society, because of challenges of funding, we end up sliding a bit on this role. But this role is critically important for us to achieve SDG 3. Civil society must identify the needs of communities. They must evaluate those needs in order of priority. They must advocate, lobby, negotiate, and do whatever it takes. And they must also recommend to political leadership programs and services to address priority needs, resources needed to meet these needs. They also must recommend or determine the best way, including partnerships and other approaches to deliver these strategies, programs, and services. I think whoever is helping with my slides, I somehow, yeah. Can we go? Yes, that's where I'm at. Thank you. So we cannot overemphasize the role of civil society in terms of ensuring that SDG 3 is met. And next slide please. What kind of leadership do we need in order for us to achieve SDG 3? I submit that we need innovative leaders. We need leaders that are also receptive to innovation. We need leaders that are evidence-driven. In my earlier example, despite the fact that we told government or we advised government, anyway, it's something that I think they already knew, that there is evidence that sex does take place in prisons and infections are happening in prisons. Our submission fell into the deaf ears. So we need leaders who are receptive to evidence. We also need leaders who will ensure that programs are implemented at scale. We need leaders who will ensure that we invest in the right programs at the right time. Timing is key. Sometimes we may know about facts based on evidence, and it takes us ages for us to enact the much needed policies. In our case, it took us 4 years. In total, it was 6. So you can see the lapse between or within that period. Leadership should also ensure community leadership and ownership. These are critically important, as I indicated earlier on. And we cannot have business as usual. What do we need political action for? We need political action to end AIDS among key and vulnerable populations. Evidence is before us that men who have sex with other men and gay men are 22 times at risk of infection than the general population. We also know that in our beloved Africa, there are quite a number of countries that have anti-LGBTI policies and laws. As I speak to you, civil society in Botswana had brought a case before the court. Civil society in Botswana had brought a case before the court challenging the constitutionality of Section 164, which basically criminalizes same-sex. This case was won at a lower court, which is the High Court, but later, government indicated that they are appealing. Where is the commitment there in terms of ensuring an enabling environment? I must say I'm really proud that I'm making this talk in Rwanda, one of the few countries in Africa that has decriminalized same-sex sexual conduct. We need political leadership to end AIDS among young people. We need political leadership to remove structural barriers. We need political leadership to prioritize prevention. And we need political leadership to achieve universal health coverage. There has been I'm getting there. So I just want to mention one point around UHC, that a lot of the time when we talk about UHC, we are talking about health insurances. And it's important for us to ensure that the equity is maintained. It's also important for us to show that the populations that we care about are protected and are not excluded from such programs. And lastly, we need accountability to sustain and increase domestic funding for health. We need country ownership, and we need to maintain global partnerships. We have to move from rhetoric to commitment to action. It's not over. We are facing a prevention crisis. The UNAIDS 2020 fast-track targets, they have to be met. So it cannot be business as usual.
It's my pleasure to introduce Berry DJ Nibogora. Berry DJ Nibogora works at the African Man for Sexual Health and Rights at the Law and Human Rights Advocacy Manager. Being a unique continental voice on HIV and human rights for men having sex with men and LGBT communities. This organization offers a platform for action, capacity strengthening, and advocacy. Berry's work includes supporting human rights organizations to document and respond to human rights violations, and undertake evidence-based advocacy and homegrown strategies that speak to the realities of MSM LGBT persons in Africa. Through HIV and human rights lens, Berry works advances non-discrimination and inclusion of key population. I'm going to keep it short. He's based in Senegal, regional office, but works and provides support across. A human rights lawyer with 10 years experience of activism, Berry's previous works included designing and implementing advocacy and training curriculum, providing legal aid and conflict resolution to mediation for refugees, IDPs, and Diouf in Burundi, Rwanda, and Democratic Republic of the Congo. Before joining this organization, Berry was a lecturer of law at the University of Burundi and other universities in Bujumbura. He holds an LLB in law from University of Burundi and a master's degree in human rights and democratization in Africa from the Faculty of Law at the University of Pretoria's Center for Human Rights. Welcome.
Morning. Morning, everyone. I don't feel the energy in the room. That's 2 points of qualification for the introduction that was made by my previous speaker, chair. I'm no longer based in Senegal. I'm in Johannesburg for now. And I'm no longer the human rights manager and the program director. Those are two details that I will mention. It's now my sincere honor to introduce Dr. Olawale Badari. He is the first and last speaker. Last but not least, I remember when we were discussing speakers at the community program committee as part of the second meeting of the National Steering Committee of CASA. His name came quite early, and people kept insisting we need to hear about his interventions in terms of using community intervention and technology in DRC and in Nigeria. So until 3 weeks ago, Dr. Badari was a senior technical advisor in the Caritas Nigeria HIV project, delivering ILVs to over 51,000 persons living with HIV through 197 hospitals in southern Nigeria. Dr. Badari is a public health physician with 15 years of experience in the Nigerian HIV response. He was leading a 40-person strategic information team and is a focal person through the GRAIL. GRAIL is an acronym that stands for Galvanizing Religious Leaders for Accelerated Identification and Linkage to Patriotic IRT project. And that project uses innovative case identification strategies to detect, identify HIV positive children in the communities. Dr. Badari obtained his medical degree from the University College Hospital in Ibadan and has undergone training at the National Postgraduate Medical College of Nigeria and also attended the University of Stellenbosch in South Africa. He obtained a number of certifications specific to HIV, and he's presently the curator of the Society for HIV Care Clinician in Nigeria. Dr. Badari is now, as I said, for 3 weeks from now, he was appointed as a technical director of RISE of ICAP in Nigeria. Dr. Badari also contributed to the national guidelines for HIV in Nigeria that was designed and adopted in 2016. Ladies, gentlemen, and others, please help me welcome Dr. Badari, our next speaker.
Good morning, everybody. Good morning. Thank you very much for that very warm introduction. I'd also like to thank SA for the honor and privilege of making this presentation. Next slide. Okay, so that's the outline for my presentation, and it's really telling the story of our experience in Caritas Nigeria and Caritas DRC with support from Caritas International. And we'll look at a couple of case studies, 4 of them that have to do with community-driven strategies with faith-based leaders, and 1 technology innovation that helps us with tracking the work that we do for people living with HIV in the community. And I'll close with some take-home messages from our experience on how pillars in the community can help us achieve an end to AIDS in Africa. Next. So when I got the nomination to do this, I felt like the guy in the frying pan, not just because I was standing here in front of the crowd, but also because of the topic. When you look at community and innovation, could you please click through? Next. Let's click through. So when you look at the role communities play in the HIV response, particularly this year, as the theme of the conference. Next, please. Next. Yes. So
and it's also the theme of World AIDS Day 2019. And we look at the direction of HIV programming in terms of participatory programming, differentiated service delivery, and U equals U. The different nuances that characterize our understanding of what community is become more and more important. Next, please. Well, my story today will tell of the work that two faith-based organizations in West and Central Africa are playing in terms of how to reach those difficult villages and townships and deliver HIV case identification strategies as well as retention strategies for treatment. Next. So our focal locations are Nigeria and Democratic Republic of Congo. And next, please. So Caritas Congo, ASBL, and Caritas Nigeria are members of the Caritas Confederation, which is in over 200 countries and territories across the world. Both organizations are recipients of PEPFAR and Global Fund funding for HIV, AIDS, and TB programming, and in their own rights are established implementing partners with providing support for over 100,000 persons living with HIV combined. Now, it's also critical to say that as countries, both Nigeria and DRC bear a significant proportion of the HIV burden in Africa. For DRC, for example, when you consider the huge population, yes, we have a prevalence of 0.8% for HIV, but you have a population of over 90 million persons spread across a landmass of 2.3 million square kilometers. It starts to hit you that programming in that space is very, very difficult. And the similar situation in Nigeria, where there's a prevalence of 1.4% at the NICE survey conducted last year, a population of 200 million people, as well as a landmass of almost 1 million square kilometers. Anecdotally, but also there's evidence to support it, I just don't have it now, is the fact that there definitely won't be enough hospitals when you compare that to the number of religious platforms, churches, mosques, and traditional religious platforms that are closer to the people in their villages and their townships. Next. So the first of our case studies is something that has grown from an initiative to an established platform, which is the Baby Shower Initiative. And this timeline just shows us the experience of both organizations, where before 2016, a lot of the community interventions were implemented within that program space. It was either advocacy or OVC programming with outreaches for community testing. But starting in 2016, Caritas Nigeria implemented or scaled up from a pilot phase the Baby Shower Initiative, and subsequently started providing differentiated service delivery using patent medicine vendors. And in 2017, we implemented a mobile health program that allowed us to track the different beneficiaries that we were reaching with our community intervention. Then in 2019, working with Caritas DRC, we implemented the Grail project. And eventually this year, we rolled out what we're calling, sorry, I keep switching between we, so I'm still having that bond with Caritas. So we implemented the flagship project, which is roughly 12 or 13 weeks old now. And I'll walk through each of these projects in my talk. So next, please. The Baby Shower strategy is, first of all, a celebration of life, but strategically helps us to reach pregnant women who do not have access to antenatal services. Literature suggests that in Nigeria, between 48% and 60% of women will not have an antenatal review before delivery. And what the congregational approach of Baby Shower tried to do was going into faith communities so that during church services or mosque programs, you can reach these women and using an integrated approach, deliver health messaging, counseling and testing services, and eventually link these women to the appropriate care that they need. And the key strategy was also to increase testing for the male partners of these women. It was built using a wraparound set of services that included hepatitis B and sickle cell screening, as well as weight, height, and blood pressure checks. Next, please. And the strategy was twofold. So the congregational engagement, and congregation here refers to the faith community in that particular location. This engagement was done by us as implementing partners, where we mapped the congregations, conducted advocacy visits to them, and tried to work with the religious leader in that congregation to build a church health team that was made up of volunteers, including someone with some medical background, and prepare for the eventual conduct of the baby shower itself. The baby shower had two parts. The first one was prenatal, and we had a baby reception postnatal. Prenatally, the church leader or the congregational leader would call to the front of the church for prayers, women who are pregnant and their male partners. And there are very few communities in Africa where the pastor calls you up to lay hands on you and pray for you when you don't come out. And subsequently, the church health committee keys into that and introduces the woman and her partner to the services that were available, including the HIV test and counseling before. Documentation was done, and we expected the couple to give consent before they participated in the baby shower activity. Next, please. Post-delivery, next. So post-delivery, there was the baby reception. For HIV positive women that were identified pre-delivery, they were commenced on PMTCT, and post-delivery gave us the opportunity to interface with the mother and also link HIV-exposed infants that were identified to early infant diagnosis as well as other postnatal care. Next. So those were some beneficiaries of the baby shower initiative. Next. Next. And typically there was a mama pack that was prepared, and this pack was presented to the mother by the male partner that attended the program. These were some of the results for the location where baby shower was implemented, and significant for us was being able to achieve 61% partner tracing in these communities. Average for Nigeria is about 21% from program records, and we were also able to show prevalence of 7% amongst mothers that were tested and 4% amongst their partners. Next. So community ART frameworks that were implemented in Nigeria. Next. The differentiated service delivery models have a robust framework that include community-based and facility-based programming. And one of the key community-based strategies was the community pharmacy pickup site, where patients that were stable on therapy could be devolved to these platforms and could get their ART refills there. Next. So working with professional associations for pharmacists and patent medicine vendors, Caritas Nigeria was able to set up pharmacy refill platforms in the community. And what these platforms did was, initially they were just for refills, and patients that were stable were involved to them, but eventually patients that the care providers in those platforms were able to elicit or get their patrons to opt in for HIV testing, and significant numbers of patients were also able to know their HIV status through that mechanism. Each community ART platform was connected to a hub facility, and data from those community platforms were linked to the hub facility. In terms of technical support, there was a roving team, because primarily these were community pharmacies or patent medicine vendors. There was a roving team of clinicians, including an ART doctor and nurses, and they provided technical support in terms of quality and of care and managing adverse drug reactions and other complications. Next. So, next, please. Next. So, working with, what we tried to do here was to roll out something called, a platform called the E-Ranger. The E-Ranger is a mobile clinic that has the option of a mobile ambulance that can move from the hub service delivery platform to support any community intervention, including HIV testing and refill for ART. Next, please. The results from this project, at the end of the implementation, we had established 29 of these community refill platforms using pharmacy and patent medicine vendors, and were able to reach 26,000 people and help them to get to know their HIV results. And for that review period, this contributed to 13% of program achievement in that area. What is key? A key learning for us from this particular strategy was when you have people living with HIV themselves involved, and one of the platforms, the patent medicine vendor, was run by someone living with HIV, and his retention was significantly higher than other patent medicine vendors, even hub facilities that were in the cluster within which you're operating. Next, please. So as we were rolling out the strategies, the issue of data collection and data quality became more and more important. And what we tried to do very early was explore different mechanisms for tracking patients as they access care, whether it was for testing or for drug pickup. And we came up with the Patient Health Smart Card. And for about 9,000 women, it replaced their hospital card. And it was essentially a QR code with patient-level data that was embedded on the card. And you had password-encrypted applications on mobile devices that allowed care providers, either in a community platform or in a hospital, to be able to access the data regarding services that these beneficiaries had received. Next. So the data was secured, was cloud hosted, and there was all levels of access were password encrypted. And very, very useful was the geographic information systems that were programmed into this intervention, such that wherever the smart card was scanned, a log was kept of who accessed that patient's data and where that service was provided. And like I said, we were able to enroll about 8,900 women living with HIV using the smart cards. And the benefit was that they could move within the facilities that we support, and all we had to do was just scan this card, and their recent clinical history was accessible to the provider. Next. Okay, the GRAIL project. Now, there is, for those that were able to join us in the Caritas Internationalis satellite on Monday at the start of the conference, you may have heard a little about the GRAIL project. The GRAIL project is an acronym for Galvanizing Religious Actors for Identification and Linkage to Pediatric ART. And our thinking was that, okay, so if we're having trouble finding children in clinics, why not go to the place where they most likely will come to? And that's the religious institutions. And it's building upon our experience from the baby showers and the influence that religious leaders have. And we implemented it in Nigeria and the Democratic Republic of Congo. Next slide, please. And the idea basically was to conduct a short but high-impact training for religious leaders that emphasize HIV transmission, introducing them to the concepts behind the science of ART, especially the concept of treatment as prevention. And currently, we're now talking about undetectable, also untransmissible. And initially, they come in as clergy who are just there to get information. But by the end of the training, we try to identify a couple of champions. So they're going back to their communities, they're going activated with knowledge to, first of all, dispel stigma. So we also equip them with sermon guides that were developed during the training itself, so that during messaging, during sermons, we provide age-appropriate messaging. And with the understanding of HIV symptomatology. Next slide. We also introduced them to the Bandicin screening tool, which has been modified in Nigeria and scaled up to a risk stratification tool. And this allowed them to be able to say, based on what I'm seeing, sir, ma, your child, your son, your daughter is ill for sure, but may also have symptoms suggestive of HIV. And I would recommend that you go for HIV testing. And we've implemented this for about 24 months now. The training covered 21 of the 37 states and regions in Nigeria. And looking at the map, you see that we significantly covered almost half of the country. But it's key to emphasize that the northeastern part of Nigeria, which is affected by the Boko Haram crisis, as well as the Niger Delta, which also has some issues around access, we're able to train religious leaders there, and they were now able to take these services to communities where health facilities do not operate. Next, please. Overall, we trained 142 religious leaders and had 95 champions activated to provide services. These are the results from Nigeria. We were able to deliver age-appropriate messaging to about 21,000 persons. And from that number, adults benefited from HIV testing, but a lot of the referral were focused on children. So the chart in the middle shows the number of children that were referred for testing. And From the number referred for testing, we were able to identify 106 HIV positive children and commence 94 of them on treatment. Next, please. In Congo, similar interventions were rolled out and messaging was delivered to about 30,000 persons. Of this number, 1,779 children were referred and 28 children were identified as HIV positive and commenced on ARVs. Next, please. The achievements combined helped us to reach about 60,000 adults with age-appropriate messaging and refer 25,000 children for treatment. But what is interesting is, with support from PEPFAR and UNAIDS, Caritas Internationalis, who has been coordinating this for Nigeria and DRC, plans to export GRIL to Tanzania, Cote d'Ivoire, and Kenya. And our hope is that they continue supporting us in Nigeria and DRC as well. Next. And lastly, we'll talk about Flagship. Flagship is fullness of life as a limited strategy for high impact, and it's being implemented in the Niger Delta region of Nigeria. The Delta states in particular is one of the 7 states in Nigeria that contributes more than 50% of the HIV burden, as documented in the NICE survey of last year. It has the 8th highest prevalence of the 37 states of 1.9%. And Flagship is really an adaptation of a community-based strategy from Zambia implemented by Circle of Hope. And CDC Nigeria and CDC Zambia supported us to facilitate this. And the Flagship is essentially a nondescript health post. It's not labeled, there are no signs, nothing tells you that it's a health post. But because of the stakeholder engagement that was done at the beginning and the acceptance by the community members walking freely for blood pressure checks and other medical interventions, but they also serve as a place for HIV testing as well as HIV drug pickup. To identify, Caritas Nigeria set up 3 of these flagship health posts that were manned by 17 team members distributed across these locations. And community mapping was done using the patients that were already, HIV positive patients that were already on treatment, for us to identify communities that had the highest prevalence, where we were most likely going to get the highest impact when we established the flagship post there. Next. And the teams in the flagship post played multiple roles. So you had a nurse initiator, an ART nurse initiator, you had adherence counselors and community health workers and M&E assistants. And the flagship post served as a hub. So when they are not doing blood pressure checks or health talks for the community, they are out in the community in teams of 2, and they are testing and linking positive patients back to treatment. And the intervention has been operational in Delta State for about 12 weeks now. Next, please. The results, next, please. The early results that we have show a significant impact on the performance in Delta State for Caritas Nigeria. The first charts on the top left, just shows the overall trend of case identification using the flagship posts. But if you look at the other 3 that are not as bold, you will see that there is significant shift in the median in terms of case identification for the 3 different hospitals who receive HIV positive patients from these flagship posts. Next, please. Next. So just to close, and I think it was very instructive that Cindy, that spoke before me, talked about, in terms of political leadership, the role that religious and traditional institutions play. The social unit within the African context is very strong. As much as we can exploit the mechanisms for influencing persons in this society, either at individual level, family level, or the clusters of family and the neighbors that live in the community, the more likely we can implement programs that are impactful. Next. And in our experience, next please. Next please. So in our experience, we think that key pillars for helping us get to an AIDS-free Africa include some of the things that are on the slide before you. The first one is recognition. And recognition and incentives can take many forms. Africans are very competitive people. So when you talk about AIDS-free cities, using gamification to put communities against each other, we measure health indices. It was one way that we used to motivate or get the teams in the flagship program and the Braille program to do even more. It's critical to recognize efforts and to provide feedback. All of the presentation this morning has talked about beliefs, norms, and culture, but it's important to stress that you need to understand them first. As an implementer and as somebody that would be part of that community, which is a role that faith-based organizations play. Unlike many implementers, faith-based organizations don't come and go. They reside in those communities, they are part of those communities. So understanding beliefs, norms, and things that influence society are critical. Engaging leadership. The leaders of communities, especially in Africa, are gatekeepers, and we found that was critical both in DRC and in Nigeria. And you cannot overemphasize the trust and the need for that sense of collaboration. It is critical for us to speak the same language in terms of goals and aspirations, but also in terms of what our shared vision for our communities are. Key take-home messages for me in this presentation are to minimize the program jargon that we go to communities with, and also to realize that even though we as programmers, for example, we're looking at the first 90, second 90, and third 90, but this young man or young lady just wants to know their health outcome and have a better life. So bringing those two concepts together is very critical for success when you're programming a community. Our expectations have to be reasonable. Communities have limited resources, and basically they are subsistence. They depend on what they have, and we need to understand that when we're programming for them and allocating resources for interventions. I think something that I have taken away from the time in Caritas, especially on flagship, is the idea of letting team members of the community teams you work with see you do it, then do it themselves, then you watch them teach someone else. And I think it's a critical way to onboard team members into whatever intervention that is being implemented, but also ensure that that knowledge is institutionalized. It's key to monitor data and track performance, and also understand that if it has been done before, and I heard that a lot in this conference about not going straight up to scale and not necessarily piloting and modeling. If it has been done before in circumstances similar to that in which you are implemented, I think it makes sense to implement that scale within the resources that you have. Technology, the internet penetration and use of social media in Africa is huge. We're one of the fastest growing telecommunications and internet markets, especially mobile devices, and these are platforms that we need to leverage. And I think we can only benefit from more feedback. Feedback at community level, feedback at program level, and feedback within settings like this, so we learn from each other and improve. In closing, I'd like to acknowledge all our patients, particularly those accessing care in faith-based hospitals across Africa, my colleagues in Caritas Internationalis, Caritas Congo, my former colleagues in Caritas Nigeria, government in Nigeria and Congo DR, United States Centers for Disease Control and Prevention, Circle of Hope Zambia, thank you very much, and our donors and SAA for making this possible. Thank you very much.
Thank you very much. I think our chairs today need a special commendation for policing the time so well. Commend our speakers for not feeling intimidated and standing their ground. And of course, our new audience for the room is almost closed now for participating in this process. Let's have a short award ceremony for Transit, which is for law, human rights, social science, and political science. The award consists of a plaque, cathedral, and a cash prize from Daouda. And the award will be presented by Dr. Natalia, the Director General of the Rwandan Medical Center. He is also head of the local Data Secretariat. And the title of the winning award is Violence, Victimization, and Viral Load Failure among HIV-positive adolescents and young adults. mixed method. And it's my pleasure to announce that the recipient of this award, Catherine. Catherine is currently completing her PhD in International Health at the John Hopkins School of Public Health. She has a master's degree in epidemiology from the London School of Hygiene and Catherine's research centers on the intersection between violence and HIV among young people in Sub-Saharan Africa. And let us join me in And before we move,